Good afternoon, everybody. We are in the last session in this meeting, and thank you for the attendees to stay till now. I think we have a very interesting session. We have very distinguished speakers, and we'll start the voting now regarding myopic, presbyopic patient free of glasses. Can we have this question on the screen, please? So everyone, please vote to see which one, and then after the presentations about this subject, we'll see again the voting. So we have presby LASIK, we have laser vision correction with monovision, laser vision correction with corneal inlay, refractive lens exchange and the multifocal, or glasses. Okay, so we'll start. The first speaker will be Dr. Rafael Bilbao. He will talk about monovision laser vision correction. So please, Dr. Bilbao, come to the podium, please.
Good afternoon, Dr. Hamdy. Thank you very much for your very kind invitation to participate in this session. I'll try to present to you our results and our experience with LASIK or PRK monovision in myopic patients. Presbyopia is nowadays the last frontier for refractive surgery, and many different techniques have been described and tried in different parts of the eyes and with different procedures. Among them, monovision. The base with which we've started using monovision in refractive surgery was the use in the contact lenses, with a success surrounding 70%. We also know that myopic patients have a greater risk for rhegmatogenous than the general population, especially if they're pseudophakic, especially if the lens surgery is performed at a young age. This is why we try to avoid lens surgery in myopic patients before the age of 55 if we have other means for correct their presbyopia. What is monovision? Monovision, or blended vision, is a situation in which an eye is focused for the near distance. This is what we call the reading eye. The other eye is focused for the distance, what we call the dominant eye. Monovision is based on the suppression of the blurred image that produces a useful vision for near, intermediate, and distance. The goal of monovision is to provide a useful vision for the distance, intermediate, and near in order to minimize the spectacles need. How do we proceed with monovision? We first have to determine which is the reading and the dominant eye. And to do this, there are what we call dominance ocular test or motor test, in which we force the patient to decide with a full distance correction which is the best eye for the distance. This is done through tests like the hole in the card. We also need to determine the sensorial dominance of the eye, or what we call also the ocular prevalence test. These tests, they measure the balance of the sensory input in a monovision situation for the patient. There are several tests. The most used are the +D, or the swinging test, which is a patient with a full distance correction. You switch a +1 diopter lens in one eye and the other to see how the patient is more comfortable. After that, we usually make a try, what we call a help test, with the glasses and the correction in the determined distance dominant eye. In fact, many studies have evaluated the dominance and the reading eye, and in most of patients, no clear ocular dominance was found. There's a great variability between and within different kind of tests, And the fact or the truth is that monovision is well tolerated for most patients. The test of ocular dominance, rather than determining the right or left dominance, should be directed more towards the exclusion of clearly dominant subjects who will not work well with the monovision. When do we perform monovision? As I said before, monovision is based in the physiological capacity of interocular blood suppression. We need to have patients with an absence or moderate anisometropia, with an absence or low amblyopia, with good previous stereoacuity, with a lack of exo or endophoric shift, with a motivation to adapt to this visual system. And the truth is that in the studies performed, most of patients adapt well to monovision, and myopic patients especially, when they're in their early presbyopic age. Women do better than men. Smaller pupils do better than larger pupils due to the better depth of focus. We do try with glasses frame, but we usually don't do a try with contact lenses, except in very specific situations. And regarding the ocular dominance, there should be an absence of a strong dominance, because we need that the suppression takes place in each distance with a different eye. And regarding the conventional monovision versus the cross monovision, which would be leaving the dominant eye for reading, several studies have demonstrated that there is no clear differences in the results. How much hypocorrection do we leave in this patient? Well, around 125. This is my main goal when I perform these surgeries. If we leave more than 125 diopters in the reading eye, the binocular summation will decrease, and the stereoacuity and contrast sensitivity that will decrease too much. Sometimes I leave a smaller amount of residual myopia in younger patients. Usually when I speak about monovision to patients non-presbyopic, they don't understand it, and we don't perform it usually. It is very important that we have motivated patients to adapt to this visual system, but they must understand that there will be a higher rate of enhancement of the first laser procedure, because we need a very accurate distance correction in the distant side. And they also must be aware that they may need thin glasses for distance and sometimes long-lasting reading activities. Which patients should we not perform monovision in them? Of course, patients who are contraindicated for LASIK or PRK, patients with very demanding needs, visual demanding needs, patients with very high expectations, or patients with amblyopia and clear ocular dominance, low visual acuity in one eye, strabismus disorders, and be aware because monovision can decompensate aphoria, which is intermittent, and do or transform it into a tropia. Does LASIK monovision works? Yes, these studies and other published in the literature have demonstrated that it does work. Patients, compared to a full distance correction bilateral, will refer a slight decrease in the binocular distance uncorrected visual acuity from 1 to 0.94. There will be, however, a big improvement in binocular near corrected visual acuity from J7 to J3. And what it is most important for many activities, there will be a great improvement in intermediate binocular vision. There will be a low reduction in contrast sensitivity function, a higher reduction in stereoacuity, and a slight reduction in binocular discrimination capacity and scatter index. What are the monovision pitfalls? Well, it's a system that decreases contrast sensitivity function, decreases stereopsis, as I mentioned before. It also decreases the distance visual acuity a little bit, and patients need glasses for help for both distance and sometimes reading. They need a very accurate emetropia in the distance focus eye. It is a time-consuming for preoperative explanation for us, for the doctors. It takes time to adapt. The first month, patients are not happy, but after a month, more than 95% of patients will be very happy with the situation. And we have to explain that this situation has a limited lasting in time, which is the degradation of the clarity in their lens. What are the advantages, so? The efficacy. Patients got a good percentage of glasses independence. It's a technique with a very good predictability and stability and safety, because it's an extraocular surgery and it has no rheumatogenic additional risk. It's a very easy technique and it's partially reversible. And when needed, vision can be easily improved with thin glasses. Satisfaction results are good. It's around 75 to 90% of cases. And compared to other laser pattern ablation, we're not inducing any corneal aberrations, and we're not limiting the future in any measure for the future lens surgery. In conclusion, monovision, LASIK or PRK should be considered for the treatment of presbyopia in precataract myopic patients. It's an easy, safe, and predictable procedure. An adequate selection and preoperative evaluation and explanation will provide a reasonable degree of glasses independence, a reasonable degree of quality of vision, and a high degree of satisfaction. Thank you very much for your kind attention.
Excellent presentation. Regarding the patient, if you are doing trial for contact lens or glasses, how many days you give the patient the glasses or the contact lens for adaptation before deciding if monovision will?
As I mentioned previously, based on our experience and what it is published, we must know that patients with a normal binocular situation would adapt, most of them would adapt to the monovision situation. And this means if the patients are happy with the try we do with a glasses trial frame, it will be fine.
So it depends on the clinic?
We don't do a contact lens try, except in very specific situation in which usually monovision would not work, but for example, the patient has another contraindication for any other kind of procedure.
I mean, you depend only on the clinic, in the clinic visit. You don't give the patient a prescription for glasses for some times and then...
No, just on the clinical visit. This is why, among other reasons, I stated that it's a long time consuming technique to explain to the patient, because you have to explain and you have to make a try and you have to make sure that the patient is more or less happy after a while with the glasses. Okay.
Right.
What about the age?
The age of the patient. You prefer any, for example, you start with 41, 42, or 47.
This is what I mentioned before. It is very difficult to try to explain to a patient who has not presbyopia symptoms that you are going to leave some myopia, you're going to restrain his visual distance vision for the future.
So it is very difficult for early presbyopia.
Beg your pardon?
It is very difficult to convince early presbyopia.
Yes, this is what I mean. So usually I don't do it before 44, 45 years of age. And I usually do it until I see the patient has no clear signs of cataract opacities.
Okay. For the time seeking, please, because this is the last session. Our next speaker is Dr. Antonio Marinho. We'll talk about the laser vision correction and corneal inlay. So please, Dr. Marinho.
I will present now our experience with presbyopia inlays. We are repeating some things that were said before in previous sessions, but we'll try not to be too long. So the presbyopia inlays, at the moment there are three types of inlays, three types according not to the material. Material are hydrogel or camera inlay, but three types of inlays concerning the mechanism of action. One that is the raindrop that works for increasing the curvature of the cornea. Then the FlexiView from Presbya company that we have here on top has a positive power in the periphery from 1.5 to 3.5 diopters, and the camera that works with a pinhole effect. It's about the camera I'm going to speak because it's the camera I have experience. The camera is a pinhole inlay made of polyvinyl fluoride, 3.8 millimeters diameter with a central aperture of 1.6 millimeters, and is an extra thin implant with 5 micra thickness. The mechanism of action is increasing depth of focus, improving near vision, and very important, disturbing minimally the far vision. It is implanted in the non-dominant eye, like this is in monovision. It must be implanted deep in the cornea. The minimum depth of implantation is 200 micra, and it has 8,400 tiny holes to preserve the corneal metabolism. You see here the number of holes that have been evolved from the previous models that are going to try to preserve the corneal metabolism. According to patient selection, we need presbyo patients that ideal will be from 0, the refraction will be from 0 to 0 minus 0.75. This is our target refraction, but of course, not all the patients have that. So the patients, I will say between -5 plus 2 plus 3, we can do concomitant at the same time or in different times, the LASIK correction and the implantation of the inlay. One very important point, we need a healthy cornea, and the minimum thickness should be 500 micron. We can do 2 techniques. We have a video here. The first and the most desirable technique is the pocket technique. Created a pocket with a femtosecond laser and implant inlay, and the inlay should be centered with the line of sight. So that is, should be centered with the Purkinje image. So it's very important if the kappa distance is low, the kappa distance being the distance between the center of the pupil and the Purkinje image, it's easier to implant. Is easier to implant. Here we see the pocket created in this case with the Zimmer femtosecond laser. We are going to dissect the pocket. It's very easy. I can tell you that this is one of my first cases, so have to forgive me some inaccuracy of the surgery, but you see from one of the first cases, the surgery is very easy. It's very important to adjust your settings of the laser to a cut deeper. The settings are not the same that for a flap of 100 or 110 micron. We just dissect the pocket, and we are going to introduce the camera centered with a mark that we previously have done in the cornea, so the centration here is very straightforward and very easy. We just go with this forceps, and unlike other implants that we have seen before in this meeting, the centration of this implant is relatively easy, and this the pocket. But of course, we can have, not all the patients, as I was telling you before, had the target refraction. So in this kind of patients, we have to do at the same time the combination of the LASIK ablation and the implantation of the inlay. Can we advance the video? The video is frozen. Okay, thank you. So at this, we can do it 2 ways. The way that we see here, where we create a 200 micron flap. Of course, for this we need a very thick cornea that is not always available. We lift the flap. It's a little harder to lift than a thinner flap, but if you put your laser settings, okay, it's not so difficult. As you see here, it's a little harder. This is real time for lifting the flap. And we do the ablation with the target again of -0.75. We do the ablation and we implant inlay. Here, the centration is a little more tricky because we don't have the corneal marks. We have to do sometimes with some tentative, putting the flap back and forward just to centrate the inlay. Because many people think, and I think they are right, that doing a thick flap would create some problems in biomechanics of the cornea. Now we have a third option, that is a 2-step surgery, where we perform the normal femtolasic and then at the same time or preferably 1 week to 3 months after the first step, we insert the camera in a pocket, but the pocket now should be 100 micra deeper than the LASIK flap. So, of course, the pocket is better, less disturbance of corneal surface, better biomechanic, and, of course, is procedure of choice when possible. What we do after post-op, we do very simple antibiotic drops for 1 week, very important, steroids for at least 3 months, and artificial tears maybe forever. I see 3 months at minimum, but most of the patients use artificial tears forever. You see a post-op case here. I will show you the results of my 30 eyes implanted, where at that time I did 10 pockets and 20 with LASIK. 17 of the 30 eyes were emetropes and 13 were myopes. We have not done hyperopes, as I explained this morning, because I don't think hyperopia is are very good candidates for this surgery. This is the refraction of the camera eye. We had 3 eyes hyperopes in the camera eye. The other eye was plano, and it was a very small hyperopia, as you see there. And the results you see here, that the far vision is very good, and what matters now is this one, this uncorrect visual acuity in the camera eye, this is the fellow eye, and you see that about almost all cases are 20/30 or better, but with time there are even better, and most of the cases are 25 or better. And this is, of course, the results, near correct vision. Most of our patients see Jaeger 1.5, some 36% see Jaeger 1, but most of them, about 70%, see Jaeger 1 or Jaeger 1.5. So judging for these results, this technique is perfect. So most of the patients have good visual acuity. However, this is not translated immediately in patient satisfaction. You see here we have still about 17% of the patients that are not satisfied with the surgery. Why is this? We don't really know, but I think it's monovision intolerance, some glare and halos at night, and reading Jaeger 1, of course, or Jaeger 1.5, but not with the necessary speed. So patient satisfaction does not correlate exactly with the visual results. What about complications? In 2 years, good biocompatibility. We have myopic shift, that is dry eye. We have not seen it in our series. On the other hand, hyperopic shift, we see it in 2 eyes. Hyperopic shift, you see a little haze around the inlay, and the patient is complaining that he could not read anymore. And if you increase steroid treatment, we have the reverse of this situation in both of the cases. Oh. What about explantations? We have 3 eyes, that is a 10% ratio that we think is still a little high. Why? As I was telling before, glare at night, poor acceptance of monovision, and of course, this case with patient insatisfaction. Explantation both with the LASIK flap or with the pocket was easy, straightforward. There was no sequela. That's not really true. There was an imprint. In one case we explanted 1 year after the surgery, there was an imprint of the inlay that take a few months to get out. So if you want to explant it early, that as I said before 6 months. So in conclusion, implantation of camera inlay is fast and reversible as possible, improves the near vision without disturbing far vision. I think it's one important tool in presbyopia correction. Of course, it is not the final, for me, is not the final solution for presbyopia. However, there are unexplained issues concerning the satisfaction of the patient, like eye dominance, we see this morning, maybe centration, not so crucial as we thought before, monovision tolerance, and of course, the very well-known and unknown neuroadaptation that I think is harder here than in multifocals. Thank you.
Excellent, Dr. Marinho. Dr. Marinho, a question, please. Regarding the 3 eyes that you explant the corneal inlay, you think that the cause is monovision intolerance. Why you are not doing any monovision testing before doing the corneal inlay?
Really, I don't think I don't know if it is only monovision intolerance. Many patients, these patients that I explanted, complained of like a shadow in front of that eye, although they had good far vision. It's like a shadow, glare, halos, more that.
This is maybe due to the haze that
maybe
around the inlay. Another thing regarding the corneal inlay, you are not using the AcuTarget mentioned by
no,
the...
I'm using AcuTarget, yes.
Not manually, okay.
No, I'm using the AcuTarget, and I have seen that if the Purkinje image and the center of the cornea are almost coincidental, maybe the cases are better. And in every case, when the patient is having satisfaction, I go to the AcuTarget again to see after the surgery. But I did not find correlation between satisfaction and centration.
Okay, thank you. Great comment. Thank you very much. Next speaker is Professor Alio. He will talk about refractive lens exchange and multifocal IOL. Dr. Alio.
Hello. Now my time to convince about multifocal lenses. I have to tell you that this topic depends on age and depends on the amount of presbyopia and the refraction of the patient. So what I'm going to tell you is for those over 50 to 55, and particularly 55, they are myopes. Over 50, they are hyperops, and astigmatism in between, depending on the spherical refraction. Definitely not for younger people, definitely not for early and intermediate patients. So this talk is for those patients that deserve the refractive LASIK change. What is true is that refractive lensectomy is one of the surgeries that is increasing in popularity because the accessibility for every cataract surgeon is easy. Everybody, those that have a training cataract surgery know how to use it. To operate a soft lens is not difficult, even that is not a piece of cake. You need to know how to do it, but it's becoming more and more popular because this accessibility. What is true is that refractive LASIK change it has an environment in which to happen. The environment, as I told you, is about age, is about refraction myopic or refraction hyperopic, and this is the algorithm or the chart that we use in our organization in order to indicate either LASIK or phakic intraocular lenses or refractive LASIK change. As you see, it is dependent on these parameters, and so what I'm going to tell you is about this group of patients that are about the age and the refraction that I mentioned to you formerly. So this is the area that we are going to cover in this topic. Refractive lensectomy is easy to access, but has some contraindications. First, we have intraoperative complications, and nobody talks about this, but in normal hands, 2% to 4% of the cases end in capsular disruption. This is the truth, and this is the average, and it's published by the Swedish report about a couple of years ago. Remember that we have still in the ophthalmitis 1 in 4,000. Remember that we have cystomacular edema, 2% of incidence, whatever you do, in cases with no problems. And so if there is no free lunch in refractive LASIK change, you have intraoperative complications, you have postoperative complications, no longer you will have accommodation, so it's not going to be indicated when you have residual accommodation useful. You have PCO that happens in 30% of the cases in 5 years, posterior vitreous detachment that will be promoted by the surgery, and this is why the myopes are a risky group. Retinal detachment happens in those that are under 50. 30% increase in retinal detachment risk, as we published in British Journal of Ophthalmology in an editorial 3 years ago, and this is evidence that happens now. Macular disease, I mentioned to you, 2% of clinically relevant, because OCT is about 10% of macular thickness increase, and we have an incomplete refractive outcome, a secondary refractive procedure that happens in about 2 to 10% depending on the surgery. So we have an environment in which this a piece of cake is not a free lunch indeed. And so you have to consider this when you indicate this procedure. Indeed, in the indicating residual refractive LASIK change, you have to take this rule of thumb in order to be sure that you don't have useful accommodation. If you have other refractive surgical alternatives, this will affect your precision as well. You have to manage the risk management of your own risk, the potential for side-threatening complications. We know that some patients are in more risk, and indeed ophthalmitis, which is obviously the most rare but the most devastating. And then is to match this technique with multifocals. So multifocal lenses indeed have been developed a very important evolution, you have now bifocal and trifocal. You have lenses that are refractive, zonal refractive, which are varifocal or rotational symmetrical. You have hybrid lenses. You have pupil-dependent or independent lenses, that you need to know this, because pupil dependency is not a contraindication, but definitely selects one lens that is the only one that is pupil independent and really works. And remember, you have add-on multifocal intraocular lenses that I am using as well, that even with some problems are a good alternative for those that have already a monofocal lens and come to your office. The how to know that you are dealing with a good intraocular lens? You have obviously the optical performance, the optical bench. Usually most of the lenses do a very good job in the optical lens, but remember that optical quality and retinal quality are essential. You should ask for a lens that behaves well in the optical bench, but also that behaves well into the eye. And finally, you need a brain to understand the signal. Multifocality is not physiological, our brain is monofocal, and neuroadaptation is unpredictable, doesn't depend on talent of the people. I have found that those that are very good in learning languages are very good for this technology, and probably there is a way in which our neuroadaptation learning capabilities are there, but it's independent from the capability of the patient, intellectual capability. So my recommendation is to ask to the company about the defocus curve. This is the defocus curve of a 30 years old normal patient. The focus curve, as you see, is flat. And everything that is different, like it happens here, this is a 45 years old presbyope, will need will give trouble because lack of intermediate near vision. This is the reason that why presbyope comes to you. But anything that is different from this curve will not be physiological, and indeed the quality of vision perceived by the patient in terms of multifocality depends on how good is the focus curve matching the normal physiology of the brain. The focus curve allows you to measure far distance vision, but also far intermediate, near intermediate, real intermediate, very near, and all types of vision, and one shot. So in one graphic you have all the information, and you will see along this presentation how to identify those lenses that should be more physiological. Also, you have to define success. For me, success is to have good vision from far. It's mandatory. You need to remember we are diurnal predators. Our evolution, our phylogenetic evolution has made us to be hunters for daylight. So we are not night predators. We are daylight predators, so we need good vision from far, and good vision for me is 20/20. I really don't give up to get 20/20 or logMAR 0.1 or 0.6 in decimal scale. Adequate intermediate, it should be for computer, office, etc., should be 20/30. That means 27 decimal and 0.2 logMAR. And adequate for near, you need functional near vision with for me is J2, which is running 20/25. 0.8 decimal at 0.2 log rad. So to define success is not about one of these parameters, it's about all parameters. And then you have a happy patient not using glasses for anything. Again, this is the focus curve to target, 30 years old, a young person with no presbyopia. So how to eliminate the commercial bias, because every company comes with a different lens that is the best. How to distinguish truth from personal opinion. I have seen many podium presentations telling what is about the personal opinion, but you need data. Medicine is a science, it's not an art. How can you select based on real data what is the best for your patient avoiding trouble? And which guidelines to follow, which are going to be independent and are going to be followed by you. So what I'm going to explain to you is the evidence that have been raised by us in our own publications, about 40 in this moment, dealing with multifocality. All of them are available to you if you click PubMed with my name. So let's go to a model. A model is the monofocal model. The monofocal model is this one. This is an spherical lens, which is the Active Smart 48S. It's spherical because spherical lenses, depending on people, as you know, can increase depth of focus. This is just what is a monofocal lens with no tricky things around. And let's test against this monofocal what happens with the family and Restore family. Restore family +3 provides to you this the focus curve. This is a reference, and indeed has to be, as you see, not as good for intermediate. Is acceptable for near, definitely is very good for far. So this is a good lens for far, acceptable for intermediate, acceptable for near, but it's not as the model. But this is far away from the theoretical ideal, the focus score, because it's bimodal, and this bimodality, and all lenses that are bimodal, are difficult to tolerate in terms of neurophysiology. And this is the 2.5, a lens that in my hands has not worked at all, because it offers bad intermediate, but near vision. Intermediate vision is not as good, and far vision indeed is good. So this is a lens that is in between, but doesn't solve the problem near vision. For me, this curve is away from what is physiological, and is not my favorite lens at all. So now let's test with the LISA family, the size lenses, against this lens, which is a size lens as well, but monofocal. This bifocal, definitely you have a bimodal profile. Intermediate vision is definitely not good. Near vision is as good as far. So this lens provides better near vision than the surplus 3 intermediate vision is less good, but definitely far vision is as good in comparison as near. This is indeed not a physiological profile, but look how different is the trifocal profile. This trifocal profile matches much better what is going to be expected in a plateau configuration, and this lens is good for far, is good for intermediate, and is acceptable for near, even that is not as good as the bifocal. Again, there is no free lunch. If you divide the light in a third focus, near vision should not be as good as in the bifocal model. This is now the Oculentis family, a lens that I like very much. This is the varifocal near vision at 1.5. You see that the profile is definitely different from the monofocal. It's not definitely physiological, but intermediate vision is good. This is a very good lens that in intermediate vision and not very highly demanding places provides to you a very good outcome with low photic phenomena. But the champion is definitely the M+3, and we have evidence now the MX. The Oculentis M+3X, which is slightly better for near. As you see, you have a profile that is almost a plateau. This lens should have the minimal physiological adaptation. The rotation should be very sick, what happens in real life. We're not talking about photic phenomena, that indeed is another problem, but indeed you have far vision, sacrificing a little bit the near vision is slightly less good than with the +3, which has been solved now with the M+3X, and intermediate is excellent. So this is a very physiological, very good profile. Now let's go to the fine vision, a lens that is a trifocal lens, as you see, has a bimodal profile. It's not as the others, the trifocals that definitely provides. The trifocal from size and the varifocal from Oculentis has an intermediate vision which is less good. Near vision is at the levels of far vision, but not as perfect as the others. Definitely this lens has a better profile than the bimodals, but is bimodal and is as good as it should be. And the M+3, this is one important thing that I'm showing to you, which is what happens against the acrylisa. As you see, if you compare this lens, we know, and we implanted a lot of them, some patients were not happy. Explantations happen to be in about 1 in 200 to 1% about. This lens is very seldomly explanted in my hands, and simply talking because we have a plateau profile, neuroadaptation is probably one of the best and easiest for the patient. So the effect of a CTR is important. We use a CTR in every patient with multifocal lens, and we have two reasons for this. The first is that it improves the outcome. Look here, the M+3 without the CTR and with CTR. You see the variability that you have and the less optimal results that you get without a CTR, but with the CTR everything becomes better. This is the paper we published. We did the same with acrylisa, exactly results. So in terms of stability and in terms of optical performance inside the eye, CTR guarantees an excellent or better performance. The second reason I do, if I need to explant the lens with a CTR, you can do it, and even that is always tricky, you can end in a successful explantation through implanting another lens in the capsular bag. Without a CTR after 6 months, you really have a different work to do. Just to remember, and this is a slide that has been projected formerly by one of my colleagues, this is the profile of a monofocal spherical lens. This is the profile of a crystal lens for HT. As you see, total monofocal, and this is the synchrony lens, indeed a monofocal lens. These accommodative lenses that in meetings have been offering 3 or more diopters of accommodation, in my hands have not worked, and look at the refocus curve. Nobody would say that this lens is accommodating if you see the refocus curve of an independent study like the one that we did. About the second reason for a bad result is neuroprocessing and related contrast sensitivity. Contrast sensitivity is indeed one issue because we are diurnal predators, so we are not prepared for mid-light environments, and mid-light environments are a challenge for us. So we need extra attention and extra performance for low mesopic conditions. And how is low mesopic contrast sensitive frequency? This is the one that happens with the monofocal lens. Look here what happens with this restore. We lose light, and as a consequence, we lose on all spatial frequencies sensitivity as well. This is about the restore plus 4, which is further decreasing the contrast sensitivity function. This is the oculentis plus 3. As you see, we have a much better profile that in high frequencies of low mesopic, indeed, is happening to influence slightly the light. This is the fine vision, which is decreasing at the same range, which is the high frequencies for low mesopic contrast sensitivity, the performance. And this is the trifocal size that is not affecting contrast sensitivity. It's, for me, something that has no explanation. If we divide light, we should have less light in each foci. Here we have a lens that doesn't offer a significant decrease of contrast sensitivity function at any of the frequencies that we have tested. Remember, we're dealing with low mesopic. If you see this graphic, and many speakers offer photopic vision, photopic vision is normal, but we are not in the need for this graphic for photopic vision. Low mesopic contrast sensitivity is what matters, and this is a problem. Again, this slide has been shown before, but it's my slide. See that diffractive technology, what you have at this moment about. The difference is about incision size, about the sphericity, about the near vision arc, about the pupil, which is very important. We have all lenses that are pupil dependent. Only the techniques is pupil independent. So for those patients who have prostatic problems, who have any limitation in terms of pupil because trauma, etc., this is the only lens to be implanted because all the others are not going to perform well. This is pupil independent, but as there is no freelance, again, is the one that gives to you more problems in terms of glare. And there are clinical studies published by us in all these lenses, not in the Technic Symphony so far. And this is what happens in refractive technology, in which you have 2 millimeters for the oculentis family. Reiner has 2.75, and we have neutral sphericity in all of them. Near that, as you know, you have a lens which is only 1.5, which is the oculentis working well. Pupil dependence is happening in all of them, and the results have been published in all these slides, in all these cases. If you go to intraocular optical quality, in the studies performing, studying the PCF and the MTF of these lenses inside the eye, you have good in all, but the best is for sure the Restore. Restore family offers the best optical quality inside the eye, probably because of the quality of the material, followed by this lens, which is from Israel, the C lens, and the others are about, but not as much as the others. You have the sense of conductivity decrease in some, in all of them. It is claimed that Symphony doesn't decrease, but I have no data on that. And indeed, this is the problem that you have. Night vision is affected in most of them. The indication is universal, with the C lenses are bifocal, and you have to customize according to the people, as I mentioned to you formerly. And concerning the refractive family, we have similar optical qualities. We don't have that about the Reiner. The conductivity is not affected for the oculentis family. The outcome is good for near vision and intermediate for the +3, only for intermediate vision for 1.5. And as you see here, the better outcomes are found, depending also not in extreme pupils. So modern intraocular lenses that we do have lenses that are better than before. You need to know the performance, and basically the performance is offered to you by the focus curve. The focus curve involves neuroprocessing, so those lenses that are far away from what is physiological will be less tolerated by the patients. You find important differences among lenses, so not all lenses are the same indeed, and you have to be sure that you are indeed to find the way to get adequate information. There is no accommodative intraocular lens at this moment available. We are working a new model, but it's not yet commercially available. And of course, the art of selecting the adequate lens depends on your information, on your unbiased information need, and the art of being a doctor. And I thank you very much for your very kind attention.
Thank you, Dr. Alio. Nice presentation. For the sake of the time, because we are too late now, we are going to postpone any question after finishing the whole session. So our next, now if you have time for the voting for the first question, was myopic, presbyopic patient free of glasses. Okay, so laser vision correction with monovision is the leading. Okay, so our next speaker, we have also a voting for post-LASIK ametropia with thin cornea and normal cornea topography. So we will see before the presentation. So glasses or contact lens is more leading than laser surface ablation with mitomycin, and Phakic IOL is the least. Okay, so our first speaker in this debate will be Dr. Antonio Marinho, who will talk about laser surface ablation and mitomycin. Okay, please, Dr. Marinho.
Okay. I will try now to defend the position that after a post-LASIK ametropia in thin cornea, I will prefer to do laser surface ablation and not lift the flap. I will show you why is my preference. First, we have to know that the mechanism of action of myopia is ablating the central cornea, changing the corneal shape, flattening the cornea, and of course changing the contours of the cornea. We have to bear in mind always the characteristics of the normal cornea, that is between 480 and 600 micra, and a mean curvature of 43 between 39 and 46, and of course has an aspheric shape without edges. So when we do LASIK in a thin cornea, let's go a little backwards. When we cut the LASIK flap, we cut through the strong cornea. We have to have a minimal residual stroma between 250 and 300 microns. And of course, if you don't respect that, we can have problems. And one problem we have a lot is regression. Of course, if the cornea is primarily thin, or we did a very deep ablation, but now what matters to us is the first case. If the cornea was already thin, regression will be more frequent. So this problem of post-LASIK ametropia is more common in my hands if the cornea was thin before. So it's really an important point. Regression, let us remind you, regression is not ectasia. We are not dealing here with ectasia. Ectasia, you have to do cross-linking, corneal rings, and so on. It's not the point here. What we have is regression, and regression is defined as what we see here on top. This is regression, this is ectasia. Regression is loss of effect, so appearance of a new myopia without increase of axial length, so it's not progression of myopia, and with no topographic abnormalities. So why there is regression? Mostly because of epithelial hyperplasia and corneal remodeling because of the excessive flattening of the cornea. So we do LASIK in thin cornea, we create an unstable cornea, we have regression. So if we have regression, we can have two options, and there are these two options that are here in discussion. We can lift the flap, and you can do it flap. I have lift flaps for 10 or more years after the primer procedure, so you can do it and then ablate the stroma. This is one option. The other option will be to ablate the flap, doing a surface ablation. Of course, which are the difference between these two positions? If you lift the flap, of course, you ablate the stromal bed. So if the cornea is already thin, so if the cornea is weak, you are going to weaken the cornea more. So what happens when I did that, and I did that in the past, is that sometimes 1 year after, the patient was exactly the same as it was before the enhancement. So you weaken the cornea more, we get regression again, we get more regression. And so you have also complications. And one complication that is a mighty complication, we have seen different strategies to deal with, it is the epithelial ingrowth. Today with the femto lasers, we don't see epithelial ingrowth in primary cases. It's finished. We don't see it anymore. But in retreatments, and in my experience, if we lift the flap years after the primary procedure, epithelial ingrowth has a certain rate, not a very high rate, but a certain rate, and with all the complications associated. On the other hand, if you do surface ablation, you ablate the flap. Ablating the flap, as you know, the flap does not count for the strength of the cornea. You don't weaken the cornea anymore, so you don't have regression, or you have less regression. So you are having the best of two worlds. You don't weaken the cornea, you don't have regression, and almost you don't have complications. We'll be there in the complications in a minute. So post-LASIK hemetropia in thin cornea is generally low hemetropia, because if it is a high hemetropia, we must think, for example, in a phakic IOL. We're not dealing with that. It's a low hemetropia. And for me, PRK with mitomycin is the procedure of choice, because, as I said before, PRK on the flap does not weaken the cornea further. What I do in my practice is I do alcohol-assisted PRK, is what I do in normal PRK. I just put the alcohol solution for 20 seconds in the cornea, then I take with a Merocell sponge the epithelium out, ablate the flap using the mitomycin C in most of the case, although if the ablation is small, I can do without it. The refractive results are not different from standard PRK, although in some cases it seems to take longer to recover the vision. But it's at the end, at 3 months, like 3 months follow-up, the refractive results are not different from standard PRK. And more important, we have not seen higher incidence of haze in these cases. This is different if you do, and in this case I'm going to tell now, mitomycin is completely mandatory, if you do PRK on PRK. So you have done a PRK before, and you do an enhancement with another PRK, there the haze, the incidence of haze is much higher. Here we don't see higher incidence of haze than in standard PRK. So, do we never lift the flap? We do it sometimes, but we only lift the flaps in 2 situations. If, of course, the result was not good at the beginning, because many reasons, because the laser was not well set, because the cornea was wet, we don't know. If we do a case of -5 and we finish at 3 months with -1, of course, in this case, the primary result was not good, and we lift the flap. And also, we lift the flap up to 2 years if there is a progression. For example, in a young patient, we see that the axial length has increased. It is a progression, not a regression. Then we lift the flap if the cornea is thick, if the cornea is good. On the other situations, we do not do it. So in conclusion, PRK for us is the procedure of choice in post-LASIK hemetropia, mostly in thin corneas, because it gives us good and stable results and gives no complications. Thank you very much.
Thank you, Dr. Marinho. Perfect in time. Our next speaker, Dr. Safwan and Bayati, please. The speaker should limit to the timing, please.
Good afternoon, everybody. Always Antonio, facilitating my work, make my work easy, and make my talk easy also. So thanks, Antonio. Well, post-LASIK hemetropia, as Antonio said, he reduced all the things for me, and the talk in this way. Still, I'm saying that there is a hope that we can lift the top. It's not my talk. Ahmed, bas. Yeah. I'm very sorry for that. It's just like the slide before. Yeah. LASIK is still the leader for the refractive surgery pack, but even with steadily improving technology, missed target, as Antonio said, an unhappy patient occasionally turn up. LASIK itself idea about how to manage it continue to evolve. So lift the flap or PRK. We are usually Sorry for that. We are usually going to use one of them, of the two. Routine for LASIK enhancement. Relift the flap and do LASIK or do PRK on the top of the flap. But the decision comes down to weighing the risk of epithelial ingrowth, post-LASIK ectasia, and which mean progression, progression and regression with a LASIK versus slow visual recovery, risk of haze that associated with PRK. It's not coming. Let us talk about risk following PRK. Subepithelial haze, the medication used is longer with a slow visual recovery and pain post-op, which is beyond patient expectation. Infection, non-planned flap displacement during mechanical epithelial removal, which increase the rate of epithelial ingrowth. And that happens, Antonio. Risk following lifting the flap, epithelial ingrowth. The incidence of usually, primarily LASIK, it's about 1%. And that, during the first 3 years, it starts to be 2%. And it comes to be around 7% after that. So 7% after 3 years means that if we will remove that flap after the third, we will have 7, and that continue up to 10 years, as Antonio said, that we can remove the flap even after 10 years. Now, ectasia. Well, most of ectasia patients that's been treated for ectasia, they had an enhancement. Progression, that's another complication that is usually associated with. Now, lifting the flap, I will say here, I will use PRK in this condition for those usually unsatisfied patients that have a problematic flap. Buttonhole, incomplete flap, decentered flap, microstriate disturbing their vision, insufficient cornea bed thickness below 250 micrometer, epithelial basement membrane dystrophy, neovascularization especially across the flap edge, history of ingrowth either in this eye or in the other eye, then lifting flap should be avoided, contraindicated here. And PRK is a second opinion is better here. Now, sorry. So lifting flap after all these, is it possible? Well, in my opinion is that it's possible in certain conditions. That condition, we can discuss it through, first, normal flap, no buttonhole, no decentration flap, the flap shouldn't be irregular, no microstriate, and of the flap surface. That should be documented by anterior OCT. Thickness of the bed should not reach less than 250 micrometer after the enhancement. And that's definitely, I will show you how to document it by the OCT. The enhancement optical zone should not exceed the flap bed outer border. That OCT shows clearly that by it we can document or we can support the topography, which we said that, well, pachymetric value or pachymetric information coming from topography for the re-enhancement is not reliable. OCT can support our documentation for the central thickness and peripheral and the flap thickness. So it gives us an information that for how much that we will consume as a tissue, consumptions, and how much we will reach at least after, and the central pachymeter. At the end, I will say that well, if we will add the LASIK extra, no, please just return back to the movie. Just can we return back to the movie, please? Sorry for that. If we can add a LASIK extra, the cross-linking partial 2.5 minutes exposure with 2.5 minute ultraviolet light, well, I know that it's not documented. There is no good support still, but 25,000 patients being treated in this procedure. And that shows that lifting the flap, and I treat this patient with enhancement and then cross-linking extra, a partial cross-linking. That cross-link will help us to reduce the rate of epithelial ingrowth and the rate of progression and the rate of the regression. We need to support this idea. We need to support this procedure by data for future, but it will give us a hope that we can do it, but still I'm following the same criteria as I'm doing it without. Thank you.
Excellent, Dr. Safwan. Our next speaker will be management of cases with thin cornea and normal corneal topography. Please, Dr. Bilbao.
Thank you very much again for your invitation. I'm going to kind of repeat the talk my previous colleagues have performed. Let's see if we can clarify some of the concepts about the enhancement management after previous LASIK or surface ablation in patients with thin corneas but normal topographies. LASIK is the most popular refractive surgery worldwide. It is a very successful technique, but residual refractive errors are possible. And these are due to under or hypercorrections, induced astigmatism, or regressions. The main indication for retreatment is patient dissatisfaction. With his visual acuity. This is something to consider. We all know LASIK distorts corneal biomechanics, and in extreme circumstances, this can lead to a corneal ectasia. Many risk factors have been described for postoperative ectasia. Possibly the two most important are the abnormal preoperative corneal topography and the insufficient residual corneal thickness after the surgery. Regarding this last issue, this is something we were very worried since the beginning of our practice. Since 1999, we routinely perform intraoperative corneal ultrasonic pachymetry to precisely calculate the residual stromal bed thickness after the laser ablation. And we advocate the use of thin flap LASIK. We always try to respect the photoablation mathematics that were advised by Mashhad many, many years ago. Although we know there is no truth number or a perfect value for all the patients, we usually don't perform LASIK in corneas thinner than 500 microns or 480 microns. We usually don't do ablations more than 20% of the total thickness of the cornea, and we usually leave a residual stromal bed of 300 microns. And as you can see in the left drawing, thinner flaps provide more residual stromal bed, and this means more safety for our patients. Regarding surface ablation, we try not to do laser ablation in corneas thinner than 470, 460, and we try to leave at least 400 microns of final corneal thickness. This corneal photoablation mathematics should be respected in primary treatments, but more thoroughly in enhancement procedures, due to the inherent inaccuracy and variability of the pachymetric techniques and the new inaccuracy and factors that a second procedure will introduce in our patients. How do we handle a patient in the situation we've just mentioned? The first thing we have to do is a thorough evaluation of the patient. We must consider the patient refractive initial status. We must do a detailed slit lamp exam, looking for the first flap characteristic. We should see if it has any epithelial ingrowth, especially at the edges of the flap. If there's been any haze, what's the size, what's the situation, where's the hinge, if there's a free cap. We have to consider the dry eye situation of this patient who is searching for a second surgery, because dry eye is the most common complication after LASIK, and an abnormal tear film contributes to a poorer refractive and vision of the patient. Treatment with artificial tears or point and pluck can improve this corrected and uncorrected vision of the patient. We must consider it before any enhancement, because sometimes in low refractive errors, this may avoid any additional surgery or an additional surgery. Make sure, this is very important, make sure of the stability of the new ametropia. If the patient was not evaluated recently, wait for 6 months and confirm refractive and topography stability. If no stability is confirmed, no retreatment should be performed. Check the lens status. Sometimes this patient may be starting a cataract. Check the topographic pattern. A small superior decentration could be an initial sign of a corneal ectasia. Check all the previous LASIK parameters: preoperative corneal pachymetry, amount of laser ablation, flap thickness to calculate the residual stromal bed. Sometimes an anterior segment OCT could help us to determine the flap thickness and the residual stromal bed. This is what we're playing with. This is our weapons. If the patient was operated elsewhere, ask for the data and the medical reports, and ask for preoperative topography. Follow the LASIK mathematic rules to decide if for this specific patient in which a treatment has to be evaluated, a LASIK enhancement is the best option, surface ablation is the best option, or no more corneal photoablation can be performed. If we decide a new LASIK enhancement, 2 options we have: relift the flap or recut the flap. If we decide to recut the flap, it's better not to do it. Always better relift than recut. Recutting has a worse safety and refractive stability results than relifting the flap. Do not recut a new flap, except if we have an initial very thin flap and a very thick cornea. Then a larger and deeper flap could be created, but this is not the case of our situation we're dealing with now, okay? If what we have to do is relift the flap, what we have to do it is with a Sinski hook, enter into the interface and do a fast flaporexis technique. Always perform intraoperative pachymetry. Usually flaps are thicker than they were usually measured for 2 reasons. Because there's a postoperative epithelial hyperplasia, and usually when performing intraoperative ultrasound pachymetry, the humidity of the surface can infravalorate the thickness of the flap. This measurement can lead you to abort the procedure if no sufficient stromal bed is found. Then you have to reconvert to a later surface ablation in a second stage. Or you may perform what was described as an undersurface ablation of the flap. I have only tried to do it once, and do believe me, it's a tricky surgery. I will never do it. I will never do it again. This was described by a very good, excellent surgeon from Spain also. Flap relift. It can be performed, as it was said previously, up to 15 years after the surgery, especially when it's done with a conventional macrokeratome, of course. But it is more difficult to achieve. The longer is the time elapsed, the thinner are the previous flaps, and it's more difficult with femtolaser due to the adhesion between both interfaces. This flap relift will, of course, bring us to have a higher rate of postoperative epithelial ingrowth, that is calculated to be about 12% with conventional macrokeratomes, 2% with femtolaser. due to the vertical cut of the laser performed by the femto laser. We normally, when we perform laugh lifting, especially after a long time, we try to use a tight contact lens for 2 days after the operations. May help to avoid or to minimize the risk for epithelial ingrowth in the periphery of the flap. This is a very, very clever and tricky technique described to try to create with a femto laser just the vertical cuts inside the initial flap that makes easier the relief of the flap, creating these new edges of the flap. It produces a lower incidence of epithelial ingrowth than relifting the original microkeraton flap, and it gives an excellent anatomic and refractive results. If we have difficulties in flap relief, as we said, or we've discovered or found an insufficient stromal bed or after the previous pachymetry of the flap thickness measured with OCT, we have other options to treat over the previous LASIK. These are surface ablation, arcuate keratotomies, and Phakic IOL. Regarding surface ablation, several studies have shown it is safe and effective. However, many years ago, it was almost forbidden. Nowadays, it is not, of course. It is compulsory the use of topical mitomycin C for 15 to 30 seconds. And the techniques we use is the technique we described the other day with a circular weak cell sponge and then using a weak cell spare to release the epithelium. In our hands, it's a technique with a lower predictability than the primary surface ablation procedures. And usually, we decrease the nomogram by 20 to 30%. Regarding arcuate keratotomies, it's an old-fashioned but safe and useful technique to perform enhancement for low residual mixed astigmatism and spherical equivalent near emetropia. We can correct up to 2 diopters of cylinders, but it is not very predictable. We produce more effects in all the patients and incisions deeper and more central. There are many nomograms described. Personally, when I have to do it, I do it with a 7mm optical zone, and I do a in situ pachymetry and take 80% of the pachymetry at that point. It could also be performed with a femto laser, probably easier, but I have no experience. And regarding Phakic IOLs, ICI implant is a safe and effective correcting myopia over 3 diopters of myopia, over 3 diopters. Quality of vision and ocular surface parameters are not deteriorated furthermore, like with any additional corneal ablative procedure. However, it's a more complex procedure that would be carefully evaluated and discussed with the patient. Pearls to take home. Consider the patient's ability to cope with the residual error. Perform a thorough preoperative evaluation. Determine the risk of ectasia. Address ocular surface disease treatment. And decide if performing or not an enhancement. If there's enough residual stromal bed, relift the cap if possible. If not, you can do it with a femto with a side cut. If there is not enough residual stromal bed, or you cannot know it, better perform a surface ablation or consider a Phakic IOL. Always respect the pachymetric limits. It is always better to have an unhappy ametropic patient than an ectasia. Thank you very much.
Excellent, Dr. Bilbao. If we have time for the voting questions to see if there is any change. Okay, so almost the same. The third debate will be about the Phakic IOL. Can we have the voting, please? Question. So in 25 years old patient with high myopia, which Phakic IOL you prefer? Cachet, anterior chamber IOL, artisan, iris fixated IOL or posterior chamber phakic IOL? Names. Okay, so posterior chamber phakic IOL will favor Dr. Alaa El-Danasour. We will talk about this. Not now, I think after that, yani. So this is favor in your talk. And Dr. Tamer now will give us a talk about different phakic IOLs, a review of different phakic IOLs. Please, Dr. Tamer.
Bismillah. Thank you, Dr. Hisham. When Dr. Hisham started to think about the debate of this session, the phakic IOLs, we thought that some doctors would want to talk about the two types of the phakic IOL, but most of the speakers were going to talk about the posterior chamber. So we decided that I'll give an overview of the phakic IOLs available in the market. And just a basic principle that we are implanting an IOL to modify the refractive power of the eye. And usually the indications of phakic IOLs are those similar to the limitations of the laser refractive surgery. Again, this should be a stable refraction, not suited for laser refractive surgery with patients seeking refractive surgery. Some indications or uses of phakic IOLs like an optical causes, as we say, high myopia, relative thin cornea, which is the cornea that we have is not enough for doing the laser ablation. We want to correct the refractive error of the patient, or a thin cornea patient without possibility of doing a surface ablation, or a bland bioptic from the start to do most of the refractive error first with the phakic IOL and then do laser surface ablation thereafter. A cornea suspicious is a very important issue. If you feel that the cornea is a form of frost or a suspicious cornea, better not to use laser with it. Or after cases of stable keratoconus with or without cross-linking, and even bioptics after doing intracorneal ring segments regulating the shape of the cornea with or without, again, cross-linking. Other cases that I can see in my practice, very steep corneas, very flat corneas in cases of anisometropia in children and post-keratoplasty. The advantages of the phakic IOLs are that they are effective, predictable, and we can exchange it, we can adjust it. Stable refractive outcome, it preserves the corneal topography, doesn't change the shape of the cornea. And it's useful in abnormal cases of cornea, abnormal shapes of the cornea, frequent gain of spectacle corrected visual acuity due to the magnification of the image of the high refractive errors, better quality of vision as well, and with wide range of correction. The routine investigations for any refractive surgery, plus we have to check the anterior chamber depth of the patients, and it should be more than 3 millimeter. And the specular microscopy should be done, and it has to be more than 2,500 cells per square millimeter. And I found one of my cases was less than this, that's why I didn't do her phakic IOL. Of course, we have to check the angle or use a UBM or a caliper to measure the white-to-white. Fundus examination to be sure of that the retina is free of any problems before doing the intraocular implantation of the phakic IOL. Of course, it's a very, very important tip that for toric phakic IOLs, we have to preoperatively mark the patient in the sitting position on a slit lamp with the patient looking straight forward on the 90 meridians and the 180 meridians. So we have three main different types, or we can say there are two, but three types of phakic IOLs in the market. The anterior chamber phakic IOL were very easy, very popular 20 years ago. And then in 2007, they were discarded from the market. It is an easy, familiar, fast procedure. But the problem is that it doesn't have a toric design because it is rotating inside the anterior chamber of the eye. Cannot control the centration of this IOL because it depends on the angle of the eye. Sometimes causes halos around light, pupil ovalization, angle damage, and endothelial cell loss due to its proximity to the endothelium of the cornea. So the available type of the anterior chamber Phakic IOL is the cachet lens. It's a very nice, very easy lens to be implanted. And this is a very quick clip about insertion of the cachet lens. Just implant, we make the incision 3 millimeter or less, 2.8, to put the cachet lens after putting the viscoelastic inside the anterior chamber, and then we insert the lens inside the eye and just making the haptics, the angle foots inside the anterior chamber, and that's it. So it's a very easy operation, but again, it was not that much popular, and some of the issues happened of the cornea even with this new model of anterior chamber Phakic IOL. So will this survive? We'll know in the next talk of Dr. Antonio Marinho about this issue. The second type is the artisan Phakic IOL. The artisan is an iris fixated IOL, which can be implanted in the anterior chamber as well. And the artisan have an advantage of having the longest history of Phakic IOLs, and one size fits all cases of refractive error. It can be centered, and it's the doctor's or the surgeon responsibility to center this artisan on the eyes, the pupil of the patient. It doesn't cause any pupil ovalization. It is available to correct myopia, hyperopia, without astigmatism. Doesn't cause any angle damage because it's away from the angle, and it's a little bit relatively away from the endothelium of the cornea, so it doesn't cause much as the anterior chamber Phakic IOLs. Of course, we have the foldable types of the artisan nowadays. But it is a complex procedure. We have to use different instruments. And as I said, the centration is very important to be done by the surgeon. And if it is decentered, we have to reattach it again. Another issue is the inclination of the artisan. We have to have a good grip of iris tissue in the haptics of the artisan so that it will not fall down. It doesn't affect any pupil dilatation to allow the surgeon later on to check the retina. Doesn't cause any problems. And some studies showed that it does affect the endothelium of the cornea. Some showed that it doesn't do this much. So it's a very skillful operation. It needs a little bit of skill to adjust the artisan and the around the pupil and do the inclination. And sometimes I'm using these contact lens, Phakic IOLs, the artisan, the Artiflex, in some cases of very high myopia if the ICL is not covering this issue, number of myopia. The posterior chamber Phakic IOL are the most common one available now is the ICL and the toric ICL. It has a relative good history, but the new version, which is the V4 now, family are available. These are the one we are using, and the more recent one is that with the central hole without the need of doing any peripheral iodectomy in the patients. The same preoperative investigations, but the angle to angle has to be checked well, either again with the UBM on doing the white to white measurement with the caliper. And we can check this. We have to calibrate the calibers to be sure of the measurements of the white to white that we are using. The advantage of these Phakic IOLs that it is a very goes through a very small incision, foldable, easy to be done. it has a larger effective optical zone. You can see here that the optical zone of the lens is 5.5, but on the corneal plane it's 7.25, and even the smallest optical zone, the 4.65, it goes in corneal plane equivalent of 6.15. It's an invisible lens, so it cannot be seen easily in the daily life. And toric lenses are available. It's the least among the three types to induce endothelial cell loss. But again, the measurements is very important, and some measurements are very tricky to choose the ICL, the proper ICL size to be implanted. Sometimes it induces cataract, but this happens usually in the early designs. And the clinical significant cataract was about 1.3, and the rate decreased thereafter after the new versions of the ICLs. It's an easy procedure to be done, implanting this ICL. This is a case of patient having intracorneal ring segments and correcting the residual refractive error with the toric ICL after this. So the take-home message is that the Phakic IOLs are very good additive for the refractive surgery, and they are, with the laser refractive surgery, are complementary, they are not contradictory. Phakic IOLs cannot be used, can be used when no other laser refractive surgery can be done, and each type of Phakic IOLs has its own advantage and disadvantage, and the surgeon must wait between the advantage and disadvantage for the safety of the patients, and because it's our primary goal. And thank you for your kind attention.
Excellent review, Dr. Tamer, for the Phakic IOL. Our next speaker will be Dr. Antonio Marinho, again for the long-term complication of Gaucher Phakic anterior chamber IOL. To Marinho, please.
So, first of all, before beginning my talk, this is my last talk, or most last of the Congress, I want to thank you for the invitation and to congratulate all the organization for this very good meeting. So, my last talk will be the long-term complications of acris of Gaucher, and I must tell you that the acris of Gaucher is no longer on the market. It's like an historic lens. I used it about 100 eyes from 2009 to 2012, and the complications I'm going to see here are of this all eyes in the 6 years of follow-up that now I have. So the Gaucher was an anterior chamber Phakic IOL made of hydrophobic acrylic. It was an angle-supported IOL with 4 points of support, optical diameter of 6 millimeter, and it came in 4 sizes. Most of these 3 sizes were most used compared to the distance, to the angle-to-angle distance. And it was available only for spherical myopia between -6 and -16.5 diopters. This is the guide to implant the lens. This is the angle-to-angle dimensions and the dimensions of the lens. Basically, we put circa 1 millimeter more. The lens size should be 1 millimeter more than to angle distance. So our full series, these are all the patients we implanted, 130 eyes of 61 patients. You see the mean sphere was about -8, from -4 to -18, with low cylinder, because not a toric cases. And you see here the white to white and anterior chamber depth, good anterior chamber depth. This is very important. This is measured from the endothelium, and you see that our cases has a good anterior chamber depth. Of course, the results, spherical equivalent, they were very good. All Phakic IOLs, despite their problems, their complications, all are very precise concerning the correction of the metropia and myopia. Of this case, you see from the pre-op of -8.10, emetropia in most cases without enhancements. Which problems do we find in 6 years? First problem was the rotation. The rotation you see here, The rotation you see here, that of these 103 cases, from the first day to the first month, 16% of the cases rotate, and still up to the third year, there was some rotations, and I can say you, up to now, sometimes there is a rotation. So the theory that the lens finds the ideal position and then does not rotate anymore is not true. So there is some rotation, and you see here, of course, the incidence of rotation decreases with time, but still, even 6 years after the surgery, I saw a patient last week before coming here, and one of the eyes still, she had some rotation. The most important concern with this lens was endothelial cell loss. I can tell you that this lens was withdrawn from the market because of important endothelial cell loss observed mostly in the United States. Contrary to that, and I have seen also studies in Europe, mostly in Germany, we don't see that endothelial cell loss. This is all our cases. We have 4% at 3 years, although at 3 years is a small number of patients. But we have not seen, and we have not explanted any lens till now because of endothelial cell loss. This difference, I think, has to be with the protocol. The protocol of the Alcon company showed that the minimum anterior chamber depth was 3.2 with cornea. So if the cornea is 550 microns, a normal cornea would leave us with an anterior chamber of 2.7, 2.6 millimeters. As you see in my case I showed before, my anterior chamber depths were very deep. It's probably because of that I did not have any endothelial concerns. And I also compared the endothelium of cases that rotate and those who do not rotate, and I didn't see any difference. So rotation, although we don't like to see rotating things inside the eye, does not appear to influence endothelium. So the only complication in long-term complication I found was in 3 cases. I show you here 1 case, but I had this in 3 eyes out of 113 eyes, where there was an angle synechia that pushed the lens toward one side. This is 12 o'clock. This is the slide should be like this, vertical one. This is 12 o'clock. This is 6 o'clock. It is pulled there because of the synechia, and of course, because of that, the critical distance is reduced. So what we did, and I finished with showing this video I showed before in another session, we have to explant the lens. This was a lens implanted in 2009 and explanted in 2013, so with 4 years implantation, and you see here how easy it is to explant the lens. We have synechia probably to the angle, but not very strong, because we rotate the lens, we explanted it through a 3.2 millimeter incision, and as you are going to see, to please our friend Alaa, we implanted an ICL, as you are going to see. So this proves that it's very easy to explant. If we need to explant for endothelial reasons, we'll do the same, but for the time being, we did this maneuver in 3 eyes, 2 of this patient, and in another eye, we did that. So we dilated the pupil, and then we did a standard ICL. It was a spherical ICL in this case, a minus 12, I think, lens. And the result was very good, and very important also, there was no third endothelial loss with the surgery. So this is the final result. We didn't have iridectomy, we don't need that with the V4C lens, and this is it. So, in conclusion, I can say that this lens, although not ideal lens, I think it was not so bad in terms of endothelium as it was mentioned in other series. And of course, it was our experience. We keep following these patients, and probably later, if we have to do more explantations, we'll report them. Thank you.
Thank you, Dr. Marinho. Nice presentation. Our last speaker, Dr. Alaa El-Danasour, will speak about posterior chamber phakic IOL. Is the best.
Okay, thank you, Hisham. Ladies and gentlemen, last talk of the last session of the last day. Do you feel good? So 10 minutes from now, you're going to be free. 10 minutes, this shows 2 minutes. You can keep it in 2 minutes. Is anybody here using phakic lenses? Is anybody using the Acrisoft Cachet or any angle fixated lens? Zero. Artisan lens, sometimes. Shaky hands. ICL. Okay. Okay, thank you very much. This ends my presentation. That's
easy presentation.
Okay, in the coming few minutes, I'm going to tell you why I strongly believe that the posterior chamber phakic lenses is the preferred choice. I'm consulting for Star Surgical, who is manufacturing the ICL. Now, think of it this way. If you decide to have an ICL in your own eye, what are the criteria that you would love to see in this ICL that you're going to put in your own eye? This is how I prepare this presentation. If I have to have an IOL in my eye, a phakic lens, I want this lens to be biocompatible, stable, predictable, to preserve the quality of my vision with my spectacles. Fast recovery is important, but it's not first priority. And because we know that many of these lenses are going to be removed one day, I want the lens to be easy to remove or exchange if needed. So let's go through this list of criteria and try to compare the ICL with the other lenses available. If you go to the biocompatibility, these are the four structure in the eye that might get hurt with a phakic lens. The endothelium, the most important, and with the endothelium, the posterior chamber lenses, for obvious reason, are the least notorious to the endothelium. The anterior chamber angle might get damaged with the lens fixated in the angle, and again, the posterior chamber lenses are the least to induce damage of the angle. Iris damage is maybe the higher with the iris fixated lenses, but not with the posterior chamber lenses. The only thing that posterior chamber lenses might induce is cataract, more than the anterior chamber and posterior chamber lenses. So, and this comes last in terms of importance. Endothelium is the most important angle, iris, and then cataract, because the cataract is the only one that can be easily fixed in these cases. I always remember, I'm quoting here our friend, the late Joseph Collin, when talking about the anterior chamber angle fixated lenses, when he said, the typical clinical presentation of these lenses is someone who had the anterior chamber cachet lens, in this case, very happy with the refractive outcome, then he disappears for a few years, and then he comes back with a complaint of fogginess, especially in the morning, and on examination, you discover starting endothelial decompensation. That was the start of the story in Europe before the cachet was withdrawn from the market in Europe. That was in 2006 or 7. Chronic uveitis might happen. I've seen in my own cases, two cases with chronic uveitis with the foldable artisan, not with the PMMA lens, but with the foldable artisan. This is one of them, and I remember this patient very well. I remember her name. I still have her phone number because she keeps calling me. I know that she was minus 10. Then we put the Artiflex, very happy for the first month. Then 2 months later, she came with chronic uveitis, treated, then recurred again, then synechiae, then removal of the lens, then phaco-IOL, then PCO, yak capsulotomy, retinal detachment, and you went through all the complications as per the book. And I remember her very well. Posterior lenses induce more cataract than anterior chamber lenses. We are not saying that they do not induce cataract, but the rate of induced cataract by posterior chamber lenses is very low, less than 0.5% in my hands. And today, with better sizing, with the anterior segment OCT and more the high-frequency ultrasound, we can get better sizing, and we are getting better and better. Maybe this is the only unfinished business with the posterior chamber lenses. With the V4C, sizing becomes less important to some extent because we have a better aqueous flow. The main reason for developing cataract is not touching the lens during surgery, because in every single ICL patient that you're going to implant, you're going to touch the crystalline lens with the ICL. If you do this, if you watch your own videos with the lens unfolding, you're touching the crystalline lens, but this is not harmful. But the most important reason for developing cataract after posterior chamber lens is to have some aqueous entrapped between the lens and between the crystalline lens and the ICL. So having this central hole with the V4, with the V5, with the V4C now is really helpful, and I think that this will even decrease the already low incidence of cataract, especially with high volts. These diagrams are from Shimizu, and he's showing here how the central hole helps in a much more physiological aqueous circulation, and this, I think he is correct that this will decrease the phakic, the cataract after ICL. Always remember that cataract, surgically induced cataract is due to poor technique, not to the lens. And this is a iris fixated lenses with very bad cataract because the surgeon was so clumsy. It's not the lens mistake, but it is the surgery. So it might develop with any phakic lens if the surgery is not good enough. Stability is a concern, especially with toric lenses. You need to have a stable lens inside the eye. That was concerning me for so many years, and I was doing always the internal high-order aberrations for all these patients, looking at the magnitude and the toricity of the internal high-order aberrations. Still, I am very much convinced that these lenses do not rotate if they are properly sized. So the only time where a lens will rotate, an ICL will rotate. Tamer, please concentrate on my talk. If the lens is rotate, this will be only a small lens. So stability is important. Remember the acri-soft cachet moves inside the eye, it rotates inside the eye. The artisan lens over years, sometimes it sags in the anterior chamber, which even is worse in toric lenses. Predictability is very high for all phakic lenses. As Antonio mentioned, we have excellent refractive outcome. Predictability is much higher than any other procedure. But more important is the correction of the cylinder. If you have a phakic lens that does not correct the cylinder, this will not survive. This was the case for the PRL and also for the cachet, because it does not correct the astigmatism. You cannot do refractive surgery without correction of the astigmatism. The question is, how low should you go in your toric lenses? Most of the surgeons that I know are using toric ICL for astigmatism more than one diopter, which is acceptable. 2 and more is definitely a yes. If you have 2 or more, you have to use toric lens. Less than 1, maybe you don't need it to correct the astigmatism, to use a toric lens, given the difference in price. If the price was the same, I'll use toric for everybody. But between 1 and 2, that was my gray zone. You know, I'm always inclined to use spheric lens because it's cheaper, but for the best visual outcome, I go for toric lenses, because I looked back on my patients who have toric lenses for lower amount of astigmatism, and I documented that these patients have a better vision, better outcome, and are happier. When it comes to the quality of vision, posterior chamber lenses are closer to the nodal point, so they give better quality of vision. Functional optical zone is larger, and this OPD map shows the difference between an ICL on your right-hand side and an anterior chamber lens on your left-hand side, and you can see a larger functional optical zone, which means a better quality of vision shown by the MTF graphs here. Fast recovery, all foldable lenses have very good and very fast, speedy recovery. Day one patients are very happy, and it's not infrequent that you have a patient on day one and see better than his spectral corrected visual acuity after any type of phakic IOL. Removability is very easy with the ICL, and the only thing I want you to know, if you're going to remove an ICL, the only tip that I'm going to give you is to hold the lens between the junction, at the junction between the optic and the haptic, because this is the thickest part of the lens. And you might use a toothed forceps, get a firm grip at this 700 micron thickness part of the lens, at the shoulder of the lens, and then pull it from the main incision. You don't have to enlarge the incision or use a larger size. So Vision ICL is my preferred phakic lens because it is the best, it has the best biocompatibility, and this is a big thing because in the future we are going to see more and more posterior chamber phakic lenses, but with different material. I'm sure we have Antonio's course, classic course at the ESCRS, doing this for 15 years now, comparing different types. Now we have difficulty finding speakers for other types of lenses, but I'm sure that in the few years to come, the debate will be which posterior chamber lens is better. ICL is best, has the best stability, predictability is the highest because it can correct the astigmatism. Quality of vision is the best because it's closer to the nodal point. Recovery is fast like all foldable lenses, and it's easy to remove. Can it get better? Yes, it's getting better. V4C is already there. Preloaded ICL V5, it's not yet commercially available, but it will be available very soon in Europe. I think they got the CE mark, and it will be available very soon in the future. It will be the same thing, but preloaded. So, in conclusion, I believe that the phakic lenses make refractive surgery safer, and as Tamer mentioned, it does not compete with LASIK. It just makes your LASIK, your laser vision correction practice safer. You don't have to push the limit at any time. A posterior chamber lens is my preferred choice. It's improving, it's continuing to improve, and more indications are evolving. And I thank you for attention, and I'll take this opportunity to thank you very much for being awake for the last minute of this meeting. Thank you for the organizing committee, Hisham and Tamer and their colleague. I think that was a great meeting. I personally enjoyed it a lot. We had very good time with our friends. I learned a lot during this meeting, so thank you very much for this great.
Thank you, Alaa, for your excellent presentation, for your attendance. Any question for the speakers? Okay, at the end of this last session, we'd like to thank all the speakers, international, regional, and national, for supporting our program in the cornea and refractive surgery and the whole meeting. And I want to thank all the attendees till the last minute. Thank you. See you in the next Maghrabi meeting, the 5th Maghrabi meeting. I don't know when, but see you there. Thank you very much.